Good afternoon, everyone. We will give people a few seconds to join the webinar and we'll get started in just a moment here. All right, good afternoon, everyone. We'll go ahead and get started. My name is Lauren Becker, and on behalf of the National Association of Community Health Centers, I'm excited to welcome you to today's Learning Lab, Improving Blood Pressure Control Among African Americans, Strategies for Reducing Health Inequities. I have a few reminders before we get started. First, this event is being recorded, and the link to the recording, as well as the slides, will be shared shortly after the end of this webinar. All attendee lines have been muted, so you should not be able to unmute your line, and attendee video has also been disabled. The chat box has also been disabled for today's webinar. If you have any questions for our panelists throughout the session, we strongly encourage you to submit them through the Q&A box. That box may be located at the top or bottom of your screen, and you may need to wiggle your mouse to wake that menu up. Now I'll turn it over to Meg Metter to review the format for today's webinar and to introduce today's moderator.
Thank you so much, Lauren. So just a quick review of how our Million Hearts Learning Labs are structured. The total time for the Learning Lab is 60 minutes, the same as a traditional webinar, but it's packaged into 3 pieces: a pre-work video recording, a pre-work survey to gather your questions, and then today's live event. Our live event will be 45 minutes and we'll be sharing at the end how you can apply for CME credits. Next slide. We have 3 learning objectives today I want to go over very quickly. The first is to describe the current state of hypertension among African Americans. The second is review evidence-based practices to improve blood pressure control and reduce health inequities among African Americans. And then importantly, our third is to discuss key actions that clinicians can take to make significant progress in getting patients with hypertension to control.
All right, great. Thanks, Meg. So my name is Hillary Wall. I'm going to be your moderator today. I am a senior scientist in the Division for Heart Disease and Stroke Prevention at CDC, and I serve as the science lead for Million Hearts. And on behalf of the entire Million Hearts team, I want to say a big thank you to everyone for participating in today's Million Hearts Learning Lab to discuss this very important topic of improving blood pressure control among African Americans. As you hopefully know, one of the Million Hearts 2027 priorities is addressing health inequities of racial and ethnic minority populations, and increasing blood pressure control among African Americans is of paramount importance to us. Today, I have the absolute pleasure of leading us through a discussion with our esteemed panelists to help us understand what the science says works and how the evidence can be applied in clinical and community settings. So let me get our rock stars out in front of you. I want to introduce our panel. We have Dr. Joe Ravenel, who is an associate professor in the Department of Population Health and Department of Medicine at the NYU Grossman School of Medicine, and the Associate Dean for Diversity Affairs and Inclusion at NYU Langone Health. And you will, of course, recognize him from our pre-taped video that hopefully you got a chance to watch. Next, we have Dr. Tony Amofa, who is the Chief Clinical Officer and Chief Academic Officer at Community Health of South Florida. This is a federally qualified health center in Miami. And we have Dr. Ali Rahimi, who is a cardiologist with Kaiser Permanente of Georgia and the Southeast Permanente Medical Group, who were named the A Million Hearts Hypertension Control Champion in 2015. He is also the CEO and president of Alika Health Technologies in Atlanta, Georgia. But before we get to our discussion, I get to take this opportunity to paint a picture for everyone. So regardless of the clinical guideline you follow or what treatment thresholds you target for blood pressure control, we have a real hypertension crisis in this country, and non-Hispanic Black adults are disproportionately affected. We know that Black adults develop hypertension at younger ages than white adults, and these are data on your screen from the Cardia study. They show the cumulative incidence in Black men and women, which are the red lines on this graph, versus white men and women, the black lines on this graph. And you can see that starting at age 20, Black men outpace the other groups for developing hypertension. And by the age of 35, Black women outpace both white women and men. This next graph highlights blood pressure control by race ethnicity. And you can see in the gold box that non-Hispanic Black adults have lower blood pressure control than non-Hispanic white adults, regardless of whether they are recommended to be on medications. And these data on the next slide are just looking at white and Black adults with uncontrolled high blood pressure. The red piece of the pie is those who are unaware of their hypertension status. So good news is fewer Black adults are unaware of their condition. Gray is people who are aware and untreated. So they know they have hypertension, but they're not currently taking antihypertensive medications. And that's almost the same proportion in both groups. But the purple pieces of the pie show people with uncontrolled hypertension who are aware of their condition and currently are being treated with antihypertensive medications. And you can see there are significantly more Black adults in this category. And again, these are people whose blood pressure is uncontrolled. So really important point. And if we go to the next slide, perhaps even more surprisingly, among adults being treated for hypertension who report having a usual source of care, the first set of bars, or report having 2 or more physician visits in the past year, white adults are across the board more likely to have their condition controlled than Black adults. And so it's with these data in mind that I'd like to open it up to our panelists. Gentlemen, please help me unpack these data. Why do you think we see these patterns of care? And Ali, maybe you can get us started.
Sure. I genuinely appreciate the opportunity to be a participant here on this very important cause. It's complicated. Patients do not wake up saying, I would like to have hypertension and it be uncontrolled and have the side effects of stroke, kidney disease, heart attack, heart failure. And I believe genuinely physicians and clinicians do not wake up saying, I want to underperform with this population. Yet there is this gap on the side of the patients. There is, competing priorities. When you look at social determinants of care, whether it be financial barriers, health literacy, what is going on at home and balance, it is very challenging, particularly when you see blood pressure being uncontrolled at an early age. And sometimes that's the age where you're trying to get some headwind financially, and you tend to ignore that. And that lack of education, understanding in the community as to how important it is. And on the other side, when you look at physicians or clinicians, this lack of urgency. And I do believe that is a major problem, whereby we have come and accepted that it's okay that the blood pressure is uncontrolled. I'll make a med titration or start one, and I'll see them back in 6 months. And that's not okay. We need to actively engage our patients and kind of move away from this current model that we wait for them to come to us, and we need to design our care around them.
Great. Joe, any follow-up thoughts?
I agree completely with everything that Ali has said. Some of the biggest reasons for differences between Black patients and white patients are not the biological ones as we once thought, but it really is these other social determinants, competing priorities, and often us not having the urgency that we need to really get the blood pressure under control.
Great. Thank you both. And so, Joe, both of you talked about urgency. How can we raise the sense of urgency with clinicians to get patients to goal? How do we, I heard you in the taped pre-work talk about the old paradigm of low and slow. How do we change that paradigm to shift more towards rapid blood pressure control?
I think it is a matter of making more providers aware of the benefits of getting the blood pressure down sooner, and also making us more aware that we can do it safely. I think there is a concern that by trying to get the blood pressure under control too quickly, that we're going to bottom patients out. The evidence just does not bear out that is a huge concern. But there is definitely evidence that getting the blood pressure under control more quickly, certainly within 3 months, ideally, and that comes from the value trial from years ago. I know that I'm pulling out a name from very long ago, but basically it looked at valsartan versus a calcium channel blocker, and basically what they saw was that the calcium channel blocker group got down much more quickly, and the benefit that they saw at the 3-month mark, where the blood pressure reduction really started to diverge, was essentially maintained throughout the entire follow-up period of the study in terms of heart attacks and strokes. So getting it down safely and quickly can have long-term benefits for avoiding those awful complications that we know come from uncontrolled hypertension, of stroke, heart disease, and end-stage kidney disease.
So what I heard is making sure we make providers aware of the benefits of getting to target quickly and the fact that we can do it safely. And so, Tony, you're in a health center. Do you have any additional tips that you've used with your clinical staff?
Sure. Thank you, Hilary. I want to underscore what Joe said. That sense of urgency is not well appreciated by clinicians, and I appreciate you sharing that study. So I would say that one of the techniques there is making sure clinicians understand the gravity of that delay, the potential consequences on patients, and the mortality difference that comes that comes with. I think is key. And then certainly, what helps also is sharing benchmark data constantly. Sometimes we don't know. I was fairly almost shocked when I found out in my health center the disparity in blood pressure control among African Americans and non-African Americans. I was pleasantly surprised that there was such a difference. So sharing the data and sharing the data by ethnicity, I think, has been a very powerful a message for all of us. And so I espouse that quite a bit. And then I think what certainly does help is working with clinicians to come up with your own algorithms for blood pressure control based on your patient population, the cost of medication in your organization, your community, and publishing that we can control blood pressure under $10, that we can control blood pressure with only 2 or 3 medications or something like that, right? Not just to patients, but to the providers, and making sure that they're involved in the development of these algorithms, so it's not a put upon. Which sometimes people can see that as you tell me what to do. I do remember that in our network of health centers, we went through an effort of actually competing for the organization that presented the best algorithm for our patient population. And that competition really worked. So I always encourage health centers to consider, have different clinicians, give them guidelines and have them come up with algorithms and compete on that. And sometimes that effort might be engaging for them. And then certainly 2 other things quickly: policing the use of those algorithms through peer review, maybe, right? Peer reviewing each other based on use of guidelines. And the last one, collecting data on the use of those medications that you're promoting. I was very pleasantly shocked when I found out after months of pushing combination pills, when we pulled the data, there was no uptick in use. And then when we shared the data, people kind of woke up to it. So I thought those are helpful engagement strategies.
Great. So using data, I love that. I'm a big fan of the data, and I love the competition for the best algorithm. I think those are really creative and innovative ideas. So thank you for those. So we've talked a little bit about clinical engagement, raising the urgency about hypertension among clinicians, but let's talk about patient engagement. So how do you raise the sense of urgency in your African-American patients when it comes to hypertension and blood pressure control? What have you found to be useful in supporting medication initiation and adherence in this population, especially if patients have been skeptical of taking antihypertensives? And Ali, maybe you can get us started.
Sure. I think that's an excellent question. When you think about, the average American adult sees their doctor 4 times a year. So that's over 360 days of lack of engagement. There's care gaps that can be left abound and open. And this is this new age where we can engage individuals where it's convenient to them at low cost, whether it's at their home, their churches, their community centers. And it does not have to be an MD or NP visit. It can be with a nurse visit, dedicated resources that are free. We look at digital health and the grand opportunity that lays before us there. Such that when the patient goes home, they're not alone. We ask them to make sure you take your medicines, make sure that you check your blood pressure, but who's that assistant that's reminding them and keeping them on tab? It's not going to be the physician nor a complex case manager that's calling them daily. So an application that can possibly they can interact with, a website that's reputable, American Heart, CDC, and you direct them to go there. And you provide them that link, you have them download it. What I oftentimes do is I have them download the link on their phone while they're in the office that says, I want you to keep reading this, follow the newsletter, subscribe to it. So, managing a chronic condition needs to be a daily, if not weekly thing. And I believe, digital health, the resources that are outside the office provide an excellent opportunity.
I absolutely love that idea of having patients get that resource open on their phone before they leave you so that it's not just passively giving them a URL. I think that's a great tip. Tony, anything else from you that you learned in health centers?
Yes, over almost 30 years of practicing in health centers, I've gotten to appreciate this unspoken distrust of healthcare professionals and our intentions for many of our patients, especially in African Americans. It's quite significant. Also, for many of them, there's this unfortunate attitude that the blood pressure can never be brought down to goal, right? Or that maybe what they have is okay. And every other day when I've seen patients, I appreciate that more and more. So one of the things that I do quite well, and I encourage all of us to pay attention to, is to be non-judgmental in our inquiry and our guidance. You have to build trust. Trust for every one of us, myself included, is crucial. And meeting patients where they're coming from becomes a big deal. So I think that certainly helps us then to understand what the issues are, and hence to know where to go from there. With that in mind, I've appreciated a lot more medication adherence issues, worse than I ever imagined over time for individual patients. Concerned about side effects that would never have come out, or the fact that, are you saying I have to be on this medication forever? Am I going to get addicted to it? Concepts that patients will never tell you that, but as you build the trust, it becomes important. So I like to say, making an effort to build the trust in our health systems, ensuring that the patient gets to see the same person over and over again is crucial to help us build that trust. But the one other thing that I find very helpful, and I have to tell you this, I have this habit of asking every single African-American male I see for the first time, every time. I ask them what made them come to see me. And 9 out of 10, it's their spouse, their wife, their daughter, some woman in their life, all the time. So over time, I've grown to appreciate that I have to use those people to influence my African-American male patients. So I ask them to come for next visits. I might call them and have that person engage in the discussion. Just one more support. I think, like Ali said, influencing their lives in their white space, we call it, is crucial. And if we don't have the resources to do that, are there other people we can harness to implement that? And daughters or dads are so powerful in getting them to, and again, maybe 3 in 10 dads might have a daughter who might be helpful, use it, right? And so I encourage working on that trust, because I know that it's made a difference in my personal life. Someone I can trust in the judgment and the guidance, knowing they don't have any malintentions, even if I don't appreciate that. Certainly making sure that they get to see me all the time. It's a weekends I return to find a health center to see whoever comes in or whoever is available, and perhaps engaging a significant other, I think, has been very helpful in my practice.
I think those are some great tips, and I'm going to take a little liberty. You mentioned medication adherence issues, and I know, Joe, in our live recording, you talked about fixed dose combinations, and you mentioned calcium channel blockers and ACE inhibitors. So I'm going to ask you, what's your go-to combo? Is it benazepril, amlodipine, or what do you tend to put patients on first?
So yes, benazepril and amlodipine is my go-to combination. I've found that because the amlodipine in particular is a very long-acting medication with a very long half-life, if a patient misses a dose or two, it's not the end of the world, and a very favorable side effect profile. We know that a major side effect of some antihypertensive medications is erectile dysfunction. If you combine that with the age at which we are diagnosing many of these men in particular, is at the age when their testosterone starts to drop and they start to have issues with erectile dysfunction anyway. And so anything we can do to sort of minimize that side effect can certainly help. And there's some evidence that if we can improve vascular health by decreasing blood pressure, that can actually have positive implications for erectile dysfunction. In addition, I find that the combination of benazepril and amlodipine is a slightly easier to manage in terms of some of the metabolic complications that come with starting out with thiazide type diuretics. That said, I have a very low threshold for adding another medication if needed, but if we can start without it, that's typically my preference. But I would love to hear from my esteemed colleagues what their go-to drugs are.
Mine is the same as well. And then I'm looking about valsartan if they cannot tolerate the ACE inhibitor. And the successes have been profound, really profound, and been supported by literature that combination fares so well long term. So I think that we have to educate our clinicians to be mindful, aware of that combination, and like Joe said, how forgiving this combination is. When life happens and you forget a dose or so, the fact that it still works, and if you miss the patient for follow-up for a while, you're safe compared to some other medications that you might have to sequence. I also like that because then when I have to sequence the diuretic next, I know that I have a protection from the ACE inhibitor, the benazepril or the valsartan, and minimizing the diuretic's effect on potassium. So I agree with you on, practically it works, and the research supports the fact that it's a very powerful combination with.
Great. Thank you both for that. I think having those concrete medications, I think, is a really great tip for folks that are listening. So Tony, while I've got you talking, again, you work in a health center, which is wonderful. I'm going to punt a question about social drivers of health. How important is it to address social drivers of health for African-American patients with hypertension? Can you talk a little bit about how you and your clinical teams are doing it? And have you found that addressing those drivers of health might help lessen the no-show appointments?
I don't think I can underscore the power of social determinants enough in chronic diseases. I think the literature and personal experiences describe that well enough. What we do in our health center is that we actually screen every patient now who comes in on a number of social determinants of health parameters. We came up with about 4 or 5 of them that we thought were the biggest drivers, so that at every new adult patient intake, as well as during the annual wellness visits, we review those with them. And with our outreach staff care coordinators, we ask them to complete the entire prepare set of questions, which may not be practical at the point of care for a regular doctor's visit. And so what we do is that we actually give the patient a history form for them to complete while they're waiting. And 95 out of 100 patients can complete that with no difficulty. But it would include, do you have any difficulties obtaining transportation or food, or some questions about homelessness sort of thing. So that the support staff then would enter the content into EHR for us. When they do that, it becomes visible to the clinician what the patient said. There's some decision support tools that light up in the EHR. But we have the privilege also of setting up such that our outreach folks behind the scenes have an automatic referral when patients hit session abnormalities and social determinants. And based on certain criteria, they know who to follow up on. But additionally, if I feel that a patient has a barrier to their outcomes based on perhaps one of the determinants that we identified, I would also get the referral to our outreach staff or care coordination team to do a follow-up. And it'd be quite effective for us. I think the key is building the screening for social determinants in your workflow is truly difficult for many of us. So we chose to select the high yield ones. So we think we can impact and embed that in a routine workflow for adult patients. However, for the staff that have the privilege of time to spend with the patients, they get to complete the entire deck of questions for several different reasons that we have them do that. So that's what we do.
Yeah.
And so one of the things we're doing now is educate the clinicians about, again, why it's important to pay attention to these things. We always have to educate. 11 times someone will say, not assume that people appreciate that transportation barrier for the patient or cost barrier or financial barrier really is more profound than you can imagine. And ask the patient, talk to the patient about them. Passes a burden trust to the patient.
Great, thank you. And I'm just looking at questions in the chat. So people asking questions, if you have any guidance on tips on patients' compliance with medication adherence. Do you have any strategies, folks forgetting to take their meds? I love what I heard before, that if you get them on the longer acting medications, maybe that's less of a problem, but any medication adherence tips? Ali, does Kaiser do anything specific?
Yeah, so we've got, by virtue of being a large integrated system, we've got clinical pharmacists that can help us. By the time sometimes folks see myself in cardiology, we're dealing a lot with folks who have resistant hypertension. So they're on 4 or more medications. A lot of folks that are hyperaldo, we're starting them then at spironolactone. I advocate that we can start that earlier before they develop the LVH and the EKG changes that we're able to show the patients. But ultimately, I think a picture says 1,000 words, and, just looking. What I oftentimes do is, by the time they see me or someone, they've got an EKG with some abnormality, and showing that to them. If they've had a heart ultrasound or their kidney function is abnormal, pointing to a picture where it shows how the heart and the kidneys and the brain are all connected with these vessels, and high pressure. And the analogy is, it's like the gas, head in an engine. Once it breaks, it breaks. So these analogies that folks can appreciate and understand. And then I assume everyone has a social determinant of, everyone's going to have some barrier to care, whether it's time, financial, stress, job related, and then open the conversation as to how can we help you, keep your follow-up? How can we help you with those medicines? And then oftentimes it's plugging them into those resources. The last thing I'll say, one area that's very underutilized, and I think we need to, what allowed us to get to 90% in Kaiser Permanente, Georgia, is we hardwired processes. So if the first blood pressure is abnormal, we check a second one so that 1 and 3 are normal then, so we're not over treating. That's the other issue. So we're not over treating patients. And the next one is providing free nurse visits at 4 weeks where they can have follow-up, where we can have titrations. It's not an MD visit with a $30, $40 copay. So I think that too will open up some space in their wallets.
Great. All right. Well, I may come back to these sort of care issues, but let's talk about patients who are less likely to seek care for just a minute. And Joe, you've done a lot of research in this area, so I'm going to ask you a compound question. Feel free to answer whatever parts you like. What are effective ways to bring hypertension care to the African-American community? Do we have, I would imagine that the evidence might be different in urban settings versus rural settings. And then can you talk a little bit about what community-based initiatives have worked to encourage African-Americans to actually seek care? So it's both like bringing care to them and then encouraging them to seek care.
So thank you for that question. We certainly know and have evidence that more engagement is absolutely key. And one of the ways that we can engage patients more around hypertension is by partnering with trusted structures and trusted organizations within the Black communities. And there are 2 institutions that are a part of almost any Black community that you go to, and that's the barbershops and the churches. And there is evidence that demonstrates that partnering with those types of institutions and structures can be beneficial for improving hypertension awareness, but also for helping with hypertension control by actually helping to address issues like medical mistrust, and also helping to navigate patients to where they can seek affordable quality care. I have been a part of studies that have partnered with barbershops. The first NIH-sponsored randomized trial of utilizing barbershops as hypertension detection and control centers was in Dallas, Texas. Myself, along with the principal investigator of that study, the late Dr. Ron Victor, one of my great mentors, we showed that barbers can be trained to actually take blood pressure and to counsel their customers on going to the doctor if their blood pressure is high. And the result of our randomized trial was a significant increase in hypertension control among the hypertensive customers who were in the intervention shops where the barbers were measuring blood pressure, compared to those control shops where they were just receiving printed educational materials. And later on in the Los Angeles barbershop blood pressure study, Dr. Victor showed that by actually bringing pharmacists into the mix, putting pharmacists in barbershops to actually help with prescribing medication right at the point of care, along with a referral network of primary care doctors that they had already sort of prearranged to work with the barbershops. That sort of full thickness, multi-level team of community partners as well as clinical partners resulted in an over 20-point drop in systolic blood pressure over the course of the study. Still one of the most impressive blood pressure drops for any hypertension drug study anywhere. And so those strategies certainly have been proven. I think where the evidence needs to go is to move from effectiveness studies to implementation studies. As happens with pretty much every single study that we know, once the grant ends and you're no longer able to fund the intervention, all of the progress that you've made typically regresses back to pre-study levels. And so there are currently efforts going on to see, can we utilize existing assets within Black communities with an eye towards creating sustainable interventions that will outlive the 5-year lifespan of most grants. And we're involved in one of those studies here in New York City, where we have from the outset started to work with federally qualified health centers, and an organization that does its work via community health workers that was around long before we got there, and they will be around long after we are gone, as well as managed care partners, payers, who by bringing them to the table at the beginning, what we're hoping to do is to develop an intervention that they will get behind and hopefully pick up the ball once our grant to look at this ends. So implementation for sustainability, I think, is really where the evidence needs to go.
That's great. So I've heard, obviously the barbershop work is something we all, if you work in hypertension, you're very excited about that. But I haven't heard the barbers referred to as patient navigators before. And it dawned on me as you were speaking that perhaps even patients, African-American patients who are in rural settings, maybe they could benefit from having that patient navigator trying to connect them with care if that's challenging. So yeah, those are some great thoughts. Thank you. We have a couple great questions in the chat on topics that we haven't really touched upon yet, which I'm surprised, but I'll open this up to all of you. Can anyone speak to your experiences in managing blood pressure using self-measured blood pressure monitoring?
Sure, I'd be happy to. It's been a hit or miss for us. Very powerful in its potential impact, but not been easy finding funding to sustain that effort, I'd say. And so we've had the pleasure of implementing this using different grant efforts with staffing support. It's been quite profound in 2 ways: enabling patients to appreciate what the blood pressures are, and enabling us to know where the blood pressures are in their white space quite efficiently. So in that regard, we found it particularly helpful. I think my challenge has been how to sustain not just funding to keep rolling this out, but the staffing infrastructure behind the scenes to make it happen, and lastly, the technology to allow us to have that real-time engagement with patients. So that's been my experience. Very, very positive, challenging to sustain. I'd love to hear what my colleagues think.
Yeah, most definitely. I completely agree with you. And I believe, that's not engagement number one, reminding that the patient, that the best advocate and to take managing your blood pressure is you. You have to know your numbers. Do you get in your car without looking at your gauges and how much gas you have or pressure in the tires? You need to pick a day of the week. You wake up in the morning and whatever that time is, and you measure your blood pressure. If the first one's abnormal, it's okay. We teach them how to take their blood pressure and take it again. Document it, keep a log. We have these, recommendations as to when they should contact us. And certainly if we've got a remote monitoring program, we'll get an abundance of data. But again, it's not about the technology, it's the individual who's using the technology and getting them engaged and having them appreciate that we figured out the medicines that manage blood pressure. We understand the dietary behaviors and that will get you to go. It's having them feel empowered, and again, providing them the resources in between the doctor's visits that they can use.
Joe, any other thoughts on SMB?
Yes, I completely agree with my colleagues. It's a very powerful tool. However, the key is making it feasible for our patients, and telling them that they need to measure their blood pressure twice a day, every day, is just it's a recipe for failure. And so I really love Ali saying, pick a day of the week and stick to that day. There is another sort of protocol that is evidence-based, developed by Dr. Tom Pickering, one of the godfathers of hypertension, where basically you tell your patients to pick one week basically where they're going to get 14 readings. Okay, they're going to get 14 readings, readings in the morning, readings in the evening, and you're basically going to you're going to average all of those, and the average that you get actually approximates the average that you would get with a 24-hour ambulatory monitor. And so, but obviously that comes with training your patient on how to take your home blood pressure, your home measured blood pressure correctly. There is an AHA protocol which can be which you can explain to your patients in 45 seconds. You can distill that 30-page document into 45 seconds, but basically it is putting your monitor on a table so that your arm is at heart level. You want to be sitting in a chair with your back supported, your feet supported. You want to turn the monitor away from you so that you can't see the numbers, because I find that when you see one high reading, your second reading is going to be high too. And you basically want them to take 3 readings at each sitting for what Ali said, which is that the first reading is often high, and then you want them to record all 3 of those readings at each sitting, and for them to bring all of those into their next visit, and with a quick calculation, you can come up with what their blood pressure looks like outside of the office.
All right, well, I feel like the 4 of us have to reconvene to just have a panel to talk about self-measured blood pressure monitoring, but I'm going to get in trouble if I don't wrap us up. So thank you for those comments. But we have about, I would say, 1 minute left, and maybe we'll start with Tony, go to Ali, and finish with Joe. What is one piece of advice you would give to practices just starting to focus on improving blood pressure control among their African-American patients?
Very simple. I think I'll run with what Joe has said before. We have to move beyond just a passionate articulation of this problem to doing something, right? Do anything, not just talk. So I would encourage all of us to have a good sense of where we are with the data in African American population and do something. But if there's one thing that I want to leave with us that maybe I haven't talked about enough, making sure that medication refilling is not a barrier. In many of our health centers, refilling medications can be a nightmare. There's lots of data that suggests writing prescription for a year, that's not a bad thing, right? As long as you have some backup protocols in place, and making sure patients who want refills don't have to go through a hustle. I can describe so many times where my patients have not had controlled blood pressures because of that. So
all right, so do something and get refill simplification as your top agenda items. I love that. Ali, how about you?
Design the care around the patient at the time and place that's most convenient to them, which oftentimes is in their home. It's not driving to an office, sitting in traffic, waiting in a waiting room and whatnot. And I believe there's that promise of digital health. Now, finding those applications with evidence that are free, that are low cost, that they can use, that can be their doctor in the pocket in between those doctor's visits, that can be empowering and engaging, speaking to them at a level of literacy that they're comfortable with, folks that look like them, that speak like them, and can gain that trust. And then hopefully we get to a state that when they come to the doctor's office, they're in control and we're reaffirming the good behaviors.
All right, Joe, you get the last word.
All right, so let's do whatever we can to help patients know their numbers. And when the blood pressure is not controlled, do something.
Great. So I want to thank our amazing panelists, Joe Ravenel, Tony Amofa, and Ali Rahimi for sharing your insights with us today. This has been such an informative session, and I think you've left our audience with not only great advice, but also that sense of urgency for helping their African-American patients achieve blood pressure control. So thank you all so much. And we've included a few resources on this slide for to help you all on your journey to achieving blood pressure control with your African-American patients, including our NAC Million Hearts Roadmap for improving blood pressure control and the Live to the Beat campaign. And I also want to invite everyone to listen in on a LinkedIn Live discussion coming up tomorrow at 12:30 p.m. Eastern about the critical role self-measured blood pressure monitoring plays in helping patients manage their hypertension and reduce their risk for a heart attack and stroke. And we're going to be focusing on SMBP telemonitoring specifically. So join us tomorrow. Thank you all. And I will turn it over to Rupi.
Awesome. Thank you, everyone. Thank you especially to our panelists for shedding light on such an important topic and patient population. We really appreciate you sharing your strategic thinking and your around improving BP control rates. Here is how to get CME credit for this particular activity today. This information will be shared with you via email, but just as a quick summary, you'll go ahead and log on to click on the activity page link. You'll be asked to sign into your AMA EdHub account. If you do not have one, you'll be encouraged to create an account online. Once you've done that, go ahead and hit start. You'll be directed towards a quiz, and you'll be able to complete the quiz and select the appropriate amount of CME to claim. Next slide. Once you've logged on, if you need to take get a copy of your certificate, there should be a button for you to download, for you to click so you can download your transcript and your certificate of completion. And then next slide. So here's just a reminder of our previous learning labs that are now available on our EdHub site, on the AMA's EdHub site as an enduring activity. So if you missed the live activity before, there's still an opportunity to access the activities via the EdHub site in the enduring fashion. There's 4 up there. There's one coming up that should be going live next month. And then lastly, just a reminder about our upcoming learning lab, which won't be until October. So more details to come there. But for now, just go ahead and save the date, October 12th at 1 p.m. Eastern Time. Thank you all.
Thanks everyone for attending.